Everyone, good morning. If you hear me, let me know. Started here in a few. Let me know if you guys can hear me so I can hear everything. Perfect. All right. Start here in a few minutes. If you have any questions from last week, feel free to post them on into the chat or onto the last. Yes, good morning, all of you. I think we left off last on vancomycin. We finished up all of our beta lactams. If that is not the case. Blue ball. Early, bright and sunny morning. Again, any questions you have, please put them up in the chat or on the sticky board. Talk about those, and if you don't ask questions, that's kind of some of the stuff can be complicated, and rather than taking like 2 hours to try to figure it out yourself, just ask a question. Clear it up pretty quick. So, I think we left off on vancomycin. No one has said otherwise, so I'm gonna go ahead and just that is the case, and then continue on. So, that prescription assignment I'm gonna get up today. I apologize for that, but you'll have 2 weeks to work on it. And then we should have a quiz next week, which I'll do through Canvas. That one will be more of like a strict timed sort of thing. It'll be like, I'm not sure how many questions, probably 5 to 10, and you'll have like 15 minutes to work on it. So that'll be pretty straightforward. That'll be at 8 o'clock. So just FYI on that one. Yeah, so I'll post another announcement. We have more questions, or we have more info on the quiz there. So no worries about that. Do you guys have Lockdown browser? What is the generation of the other penicillins? Doesn't matter. The generations only really apply so far to the cephalosporins. The penicillins don't really have that strict sort of generational naming structure there. Yeah, so you guys do have good. Yeah, so we'll do it through Lockdown browser and all that good stuff. So no worries with that. We'll get it all set up, and I wouldn't worry too much about it. The whole point is to give you some more ideas on like how the questions I might ask on exam will look there. It'll be going over a lot of the basics in terms of like mechanisms and side effects, but I want to make sure I at least finish up this section because the quiz will cover section 1 and 2, which I should be able to do. Problem. So anyway, getting on with it, we have here vancomycin. We were talking about all of our beta lactam drugs and how they worked on that penicillin binding protein. Here we're going to get into vancomycin, which is still cell wall active. It's still bactericidal. But instead of having to bind to that penicillin binding protein, it actually ends up binding to these two dealanines directly. So instead of having to go through that PBP, it's binding to the two dealanines, prevents that cell wall from structurally sound, and it just breaks open and lyses the cell. Okay. So by doing this, it overcomes a lot of that resistance that you see that a lot of these gram-positive bugs are going to have towards penicillin. And so when we're talking about spectrum of coverage, it turns out vancomycin is actually quite narrow in spectrum because it only covers gram-positive bugs. But we still use it all the time because of the main things that it covers includes MRSA. So when you go from MSSA to MRSA, so methicillin-resistant Staph aureus, this is going to be like your go-to bread and butter drug for that for a lot of cases. Right? It's not the only drug going to cover MRSA, but it's a very good one that we use quite frequently from like an IV perspective. Good for that. It's also you'll see used like in surgery sometimes if our patients have some allergy issues and things like that. The other big thing you're going to see this used for occasionally is going to be for C. diff, right? And so this is where it's kind of interesting. This is an important delineation to make between the different routes that you can give vancomycin. Vancomycin, when given orally, does not get absorbed. It has no bioavailability, right? So it's 0%. That's why you have to give it IV 95 times out of 100 because we're using it to treat systemic infection, MRSA, other things, the gram-positive. On the other hand, though, C. diff is an infection in the GI tract. And so what's interesting is you can use oral vancomycin to treat C. diff, but you can't use IV vancomycin because the levels just don't get high enough to actually treat that there. And excuse me, in fact, we're starting to see that C. diff is actually becoming, or vancomycin is becoming a gold standard sort of first-line drug for C. diff treatment there. So that's an important point there. If you ever see a patient on oral vancomycin, that's what they're going to be using. In terms of dosing, resistance to vancomycin is becoming more common, and so it can become an issue here where we have to use like sort of a backup medication to treat that vancomycin resistant Staph aureus or like enterococcus and things like that. But we oftentimes will base that off of the MIC. Vancomycin is also still going to be a time-dependent antibiotic, very similar to the penicillins and all of the beta-lactams that we've looked at here. But note here that it only really works up to a certain point because once the MIC starts to get too high, then we have to start considering like backup medications. And unfortunately, we don't have a whole lot of drugs to use as backup other than, vancomycin. There's like one or two other ones, but not very many, which is tough. So vancomycin is going to be another one where we're going to be checking trough levels, right? And we want to make sure the trough is above that MIC for as long as possible in order to ensure that it's going to be working effectively. And also we want to make sure the levels, those trough levels are not too high because then they can accumulate and actually cause toxicity. So that can be one of the things you'll see there. When you're considering doing like therapeutic drug monitoring, like vancomycin is going to be one of the most common drugs you're going to do that on. And frequently you'll have like pharmacy services that will help out with that. So you'll be dosing the patient, you'll get probably 3 to 4 doses, and then you check a trough level. And again, this is both done to assess for efficacy and for toxicity, right? Make sure they're within a certain range there. And so you can kind of see here how we can sometimes get around waiting to get to steady state by doing loading doses, right? So we're going to do a loading dose, get the patient up. We'll do this for critically ill ones. We want to get the levels at steady state as quickly as possible. And then you have to dose the interval really based off of what the renal function is like. So this one is another one that is entirely renally eliminated. And so you can see here how we don't necessarily have to change the dose that we're giving the patient, but more often we're changing the frequency. That's something we kind of talked about before back in the summertime, is talking about how the frequency or the dose can change in order to keep levels kind of where we want them. This is going to be a case here where oftentimes it's the frequency that we're giving it. So we'll get a high level and then we'll give the body as much time as it needs to clear that out. And once the trough gets down to its sort of goal level, then we can go ahead and redose that. So we can do it Q8, Q12, Q24. Some patients, their renal function is so poor, we have to just give kind of like one-time doses. And then we just kind of periodically check that level to see when it gets down to the correct trough level, and then we go ahead and redose them. So, maybe 36 hours, 48 hours, just really depends on the patient, what their renal function is really doing there. So Anyway, in terms of monitoring, these are the big things why we monitor in terms of the trough levels, making sure they don't get too high, because we do worry about ototoxicity. So they can actually have some vancomycin accumulate in the hair cells within the cochlea, and that can actually lead to permanent hearing loss, and then nephrotoxicity. So those are the two big ones you want to think about in terms of issues that vancomycin can cause. And again, this is going to be a case where patients who have really severe systemic infections frequently are hypotensive, and that hypotension is leading to kidney injury as well, which decreases kidney function. And so you can see how these things can tend to snowball on one another. So those are the big things you want to monitor for us. What we're doing the trough levels for is, for one, to make sure it's being effective, and then two, we're not going to have too big a risk of accumulation cause oto and nephrotoxicity. There's a strong infusion related reaction associated with vancomycin. A lot of antibiotics you can give over 5 minutes, you can give over 30 minutes, no big deal with those. With vancomycin, you have to infuse over like 2 hours, 90 minutes at the quickest, but 2 hours for most patients, because it can induce what they call a red man syndrome, which is probably not the most politically correct term out there, but it is accurate in terms of its effects that you'll see there. And so basically, this is something where the patient will get sort of a body-wide rash. They have some itching associated with that, fevers and chills and some phlebitis. It looks a lot like an allergic reaction, but it's not. It's just an infusion-related reaction. So if you saw someone like this, you would not necessarily need to treat it like an allergic reaction and give them steroids and things like that. You just have to slow down the infusion. So if someone were to give it over 30 minutes and they saw this red man syndrome, you could just slow it down over 2 hours, and 9 times out of 10 it'll go away, right? So that's usually the first step we're going to be doing when we see patients that have this sort of reaction here, right? Anyway, as I mentioned, we do therapeutic drug monitoring on this to make sure the troughs are in the right ranges there. Sometimes we can modify where the trough goal is based off of where the infection is. So in some cases there, certain areas of the body are more difficult to penetrate. And so we need higher levels in order to accomplish that. So for instance, like, lung infections or meningitis, those are areas where we require more drug. So we require a higher trough in order to achieve levels sufficient to kill off this bacteria. So as an example, something like, apologize for the streams going out there, intermittent there. For example, if we were doing something like, for a simple skin infection, you could shoot for a trough level of like 10 to 15 mics per ml, versus if you were having one with meningitis, you shoot for 15 20, right? So don't memorize those numbers for my test. I'm just giving some examples of how, that I can change there. A little choppy, but should pick up here in a second, I think. So anyway, here's an example what that red man syndrome would look like, and you can see that rash that develops here. What factors would you cause impaired renal clearance? Right, so when you have patients who are hypotensive, the body tends to want to it will preferentially perfuse certain organs over others. So for instance, like, if I'm critically ill with a, MRSA infection in the bloodstream, I'm hypotensive, like 60s over 30s or something like that in terms of blood pressure. That's going to be something to where, the body doesn't necessarily need to, or perfuse like the GI tract, for instance, right? It doesn't really care about digesting food; it's trying to keep you alive, and so it's going to preferentially, perfuse like the heart and the head, but other organ systems can take sort of take a back seat to that, and one of those can include the kidneys. Even though the kidneys are absolutely important to live, you can live a lot longer without your kidneys than you can without your brain. So because of that, you can see some hypoperfusion of the kidneys. Kidneys require a ton of oxygen to be active, and so when that happens, that can cause kidney injury. And so that, on top of receiving medications, it can also cause kidney injury. You can start to see that sort of snowball. And some people just have bad kidney function just due to natural aging and diabetes and other disease states that can affect that. So those are the big things there. All right. So moving on, getting next into the protein synthesis inhibitors. Again, now we're moving on from the cell wall. Now we're looking at the actual ability for these bacteria to produce new proteins. So, the bacteria, just like us, will go ahead and take their DNA. They'll translate that into mRNA, and then that will then get basically transcribed over into new amino acid based proteins, right? So one of the things we can do there is actually inhibit the ribosomes and prevent this from happening. And so, whereas you saw that by inhibiting the cell wall, that actually would cause cell death to occur, instead here what we can see is that by inhibiting protein synthesis, it's not going to be bactericidal in most cases. Instead, it's going to be bacteriostatic. So it'll take basically prevent the cell from actively replicating, but then give our immune system a chance to come in and kill off bacteria. Note here that the targets that we're shooting for are going to be different, which is why these drugs have specificity for bacteria instead of attacking us, because we have different ribosomes. Now, for my purposes, I don't care if you know whether the antibiotics work on the 50S or the 30S ribosomes. I don't really care. Just know that it inhibits cell or bacterial protein production by inhibiting ribosome. Okay. So I'm going to start with the macrolides here. These are pretty common ones you run into. So the macrolides, you have erythromycin, clarithromycin, and azithromycin. Once we get into this section here, this is where the naming conventions are not quite so useful. So for instance, just because something ends with mycin, you won't really know necessarily what it does. So like vancomycin, very different than erythromycin, right? So be able to keep those sort of distinctions in your mind where necessary. Anyway, so we have three macrolides here. Erythromycin, you're probably going to see used probably the least commonly out of the bunch here, but it's been around for forever. It has a lot of different salt forms, which can affect things like release characteristics and things like that. I don't memorize the specific ones. Just know that we do have some options there in terms of how to administer it. And then clarithromycin and azithromycin is probably by far the most common one you'll see there. Most people have either been on or seen someone receive a Z-Pack at some point in their life. Now, in terms of macrolide covers, these are going to be quite different than what we've seen with any of our cell wall active drugs. And so it's pretty broad spectrum, which is why it is used to treat a wide variety of conditions, especially a lot of upper and lower respiratory tract infections. Things like strep pneumo, MSSA, listeria can be covered by this. No enterococci, so probably no GI, infections you're going to see here. And we'll get a decent number of gram negatives, things like H. influenza, Marksella catarrhalis. This is just denoting here that azithromycin probably has the best coverage for these out of this, and then followed by clarithromycin and erythromycin. Even things like Neisseria, so a lot of these are going to be upper respiratory tract infections, causing pneumonia. You'll see these pop up pretty commonly there. And then the other kind of claim to fame that the macrolides have are, if you've ever heard of something like an atypical pneumonia, is caused by an atypical bacteria. Things like Legionella, Mycoplasma pneumoniae, and chlamydia even can be treated by the macrolide. So again, good gram-negative coverage, good gram-positive coverage, and now this is the first thing we've seen so far that has good atypical coverage. That's sort of the unique thing you're going to see with the macrolides and why they're used quite frequently for a variety of respiratory tract conditions. We'll see that in ENT and in pulmonology a little bit later on there. And you can see some of the indications here for that. You can even use it for some opportunistic infections in patients with poor immune systems. So for instance, like Mycobacterium avium complex or MAC. That's something you'll see occasionally in patients with like more late stage HIV/AIDS, or if they're on cancer treatment, sort of suppressing their immune system, things like that. Chlamydia, and then H. pylori is actually another common one. You'll see the macrolides being used for that. And that's a common bacterial cause for peptic ulcers. Think peptic ulcer disease. The two big things you think of are NSAIDs, like your ibuprofens and whatnot, and then H. pylori as from a bacterial end. And so we'll typically use macrolides for that. So in terms of adverse effects, we're going to see that nausea, vomiting, diarrhea are going to be common side effects for pretty much any drug that's out there. However, this is going to be a little bit more severe in the macrolides, and the reason for that is, especially with the erythromycin, is because it actually interacts with the motilin receptors in the GI tract, and that directly stimulates peristalsis. So the peristalsis can lead to cramping, diarrhea, things like that. And the reason why this is actually sometimes useful, because we can have children, especially, I see this all the time at Nemours, where they have impaired GI motility, gastroparesis, things like that, and we can actually directly stimulate GI tract and move things along. That can actually be a very useful thing. And in fact, I probably will see erythromycin probably 95 times out of 100 being used for GI issues rather than actual for infection. Whereas on the other hand, if I see clarithromycin or azithro, those are always going to be for infectious purposes. Okay, so can see some allergies, pretty rare. Can see some cholestatic hepatitis. This is with certain salt forms of erythromycin, so it doesn't really pop up all that often. And then most of the time, probably, again, 95 times out of 100, you're going to be seeing macrolides being used orally. So this is transient hearing loss is not such a big issue, but that's one reason why we may be more hesitant to give it IV. So we typically don't do that if we really have a good indication to do. Now this one's an important point here is this QT and QT prolongation, which you can see on the EKG. It can predispose a patient to something called torsades de pointes, which is the French term for twisting of the points. And this is a pretty particular ventricular arrhythmia you want to be familiar with, because you'll probably hear about it on the PANCE or during ACLS and things like that. And so I bring this up now because this applies to a variety of different medications, not just with antibiotics, but we'll see this come up everywhere else. Cardiac stuff, psych stuff, see it everywhere. And the thing to take away from this is that QT prolongation from a single medication is often not going to be of much clinical concern for your patients, right? You have some wiggle room in terms of extending the QTC, but when you start to add on multiple drugs that can do this at the same time, that's where you start to run into some issues, right? So once you start adding on multiple drugs that can prolong the QTC, that can then predispose that patient to torsades. Or if they are on, if that's like some electro abnormalities, or perhaps if you have a patient who is has a prolonged QT due to congenital heart defect, something like that, that's where the risk really comes in here. And so you can see this on the EKG. If you were to look at a normal sort of EKG like this, and then you look at what a prolonged QT would look like, you can see here that it's basically due to prolonged refractory period or prolonged repolarization of the ventricles. Christine is asking, does transient hearing loss, is that a reaction of macrolides? Does it resolve it? I'm not sure. I've never actually seen it in person. I imagine it being transient, trying to see here. Transient hearing loss is a reaction to macrolide. Does it resolve it? I don't. The macrolide itself doesn't resolve it. If it happens, you'd probably either switch to oral or perhaps you modify your dose or something like that to try to mitigate that. But it shouldn't be permanent in most cases there. So anyway, so again, why does this happen here? Well, basically, you're going to find that drugs that prolong the QT most often will prevent potassium efflux out of the myocyte. We'll cover the cardiac conduction cycle more specifically when we get into the cardiac section later on in this class, but by blocking potassium efflux, this extends out the repolarization period. And so what this does is actually affect how long it takes for the ventricles to kind of go back to their resting state, ready for the next heartbeat to come along. And so what that does is actually predispose certain areas to having these reentrant arrhythmias come in. And so that causes the torsades to occur here, which you can see is very typical or very kind of unique looking sort of arrhythmia as compared to like VFib or VTAC, which is does not look quite so kind of interesting in that way. And if anyone is curious about how you actually treat that, this is a good like easy pants question or a question your preceptors might ask you. Just do IV magnesium. Magnesium sulfate is the go-to treatment for torsades. Another big thing here with the macrolides is you're going to see quite a few CYP interactions, and so this is most often caused by erythromycin, followed by clarithromycin, and then azithromycin, probably the least likely to cause issues, but it still can, so you still want to be aware of this. And most frequently, it's going to cause inhibition of CYP3A4. Okay, so remember we talked about 3A4 last summer, or in the summer, and we talked about how that one is the most important CYP enzyme because it just metabolizes the most number of drugs. And so if you inhibit that, then levels of these substrates are going to go up, right? So if I inhibit the metabolism of something like midazolam, which midazolam is a benzodiazepine that causes, decreases anxiety, can cause sleep. You can see someone who is extremely difficult to arouse because maybe we're inhibiting the metabolism of that midazolam, sticks around for longer, and they're more difficult to wake up because of that, right? So it can cause pretty significant interactions here you want to be watchful for. So always, always, always check their medication list prior to prescribing, run it through an interaction checker. There's a million of them out there, and you'll have an idea of what sort of reactions to look at and see, should I even use a macrolide? Can I use something else? Can I modify the dose of the other drug that they're taking? There's ways to get around it, but you still need to know the interactions can happen. So moving on, continuing with our protein synthesis inhibitors. Next here we have our tetracyclines, which include tetracycline, doxycycline, and then minocycline. Obviously, by the chemical structure, you can see how they're called tetracyclines, right? So these are still inhibiting the protein synthesis here at the ribosomes. These are still bacteriostatic, and these are still broad spectrum. So pretty similar in terms of characteristics shared with the macrolides, but we'll see there's some differences in terms of like adverse effects and a little bit different in terms of coverage here. Um, so you're going to find that it's still going to cover atypicals. It's still going to cover coverage against your gram negatives and your gram positives here, and even get some anaerobes. And actually, one of the big things you'll see tetracyclines used for most commonly is going to be for acne, because it does get some anaerobes that grow there in the skin, which we'll probably talk about a little bit later today. And then it actually gets a lot of animal-borne organisms, so things like Yersinia pestis, which is the Black Plague, rickettsia, Rocky Mountain spotted fever, Lyme disease, things like that get treated with tetracycline. So you'll see them used most often for those sort of indications there. Sometimes it's like a backup for H. pylori, but not good for things like Pseudomonas, C. diff. So not going to be for those more like kind of severe gram-negative infections. So as I mentioned, you can see it used for acne. Usually this is going to be a backup set of medications from the macrolides in terms of its use for atypical pneumonias. And I mentioned all the animal-borne diseases here. It also has good coverage against STDs like chlamydia, which I should say STIs here. That's the newer nomenclature. But some of the things that limit its use here is why we don't see it used quite so often for a lot of these infections, why we may go with macrolides more frequently. One thing here in terms of drug interactions is it will chelate with other cations. When I say by that chelation, it means it will grab onto those other cations and prevent them from being absorbed. And it prevents the tetracycline from being absorbed. So if you had a patient who's taking doxycycline or something like that with iron and calcium, or iron or calcium, that will bind to those in the GI tract and prevent them from being absorbed. And the tetracycline from being absorbed, so that prevents the drug from working, right? So that's one thing you're going to see there. David's asking, is there a particular reason why it works selectively for some gram negatives and not others? Probably there's a reason for that. I don't know specifically what it is. It can have to do with specific targets, or if the ribosomes are different enough to where tetracyclines don't really bind all that well to it, then that could be one reason. Resistance patterns and things like that. So you'll find that. And again, if you're looking at certain resources, they will tell you specifically like what gram negatives, things like tetracyclines work for. If you see like an antibiogram or something like that, that can give you clues in terms of what's going to work for and what it doesn't. And so we'll go over some other ones that are kind of broad gram negative coverage, but don't really get a lot of other stuff. So we'll see that in just a little bit. But in terms of adverse effects, you can see some photosensitivity, which can be, troublesome, especially if patients have acne and they're on other medications that are like drying out the skin and being kind of an irritant. Make sure they're, covering up, wearing sunscreen if they're going to go outside, things like that, because it can see a little bit increased risk of sunburns and whatnot. The other thing too is that because it binds to calcium, it can do the same thing in the teeth and in the bones. And so typically you're going to see this more often doxycycline than other tetracyclines here. And for the most part, if a patient needs to be on this for more than a week or so, and especially if they're younger, so if they're less than 8 years of age, we typically will avoid the tetracycline because they can have a tendency to stain permanently the adult teeth. So that's one thing you want to watch out for there. But again, long-term use, more than like a week or so, if they're less than 8, you probably want to avoid the tetracyclines. It also can suppress skeletal growth, especially in a developing fetus, which is why we don't recommend it in second or third trimester of pregnancy. So those are the big kind of drawbacks of tetracyclines, and why in some cases you may not see them as often as something like a macrolide, because most probably 8 times out of 10 you can see the tetracycline and macrolides can be used for the same indications, and so it's just easier to go with the macrolide because the side effect profile is a little bit better. So all right, kind of an offshoot of the tetracycline, you get tigacycline or Tigacyl. This one kind of looks like a tiger if you were to look at the structure. Here's a little tail on it. I guess maybe this is a mouth, perhaps, I don't know, but it kind of looks like a little tiger, and you can see that in all the marketing too. You can see your provider walking through the hallways of the tiger. I don't think anyone's going to tell him no something, but this one is going to be not used as often as the tetracyclines. This is like an IV only product. But we used it a lot for more resistant sort of infections. For instance, if I have someone who has, a really nasty infection caused by an intra-abdominal set of bugs here, a lot of kind of oddball sort of bacteria, you don't see a lot of coverage with other stuff. But again, good broad anaerobe coverage, gram negative, gram positive, all of that. So typically reserving this for patients who have like really resistant infections, aren't treated by things like fourth generation cephalosporin, or one of the more broad spectrum penicillin, something like that. So not used as often, but at least good to mention it here in case you ever see it. Also a nice bright orange color. So if you ever see like an IV bag hanging on a patient that's bright orange, it's probably going to be vancomycin for that. All right. Next off with the aminoglycosides, these are going to be pretty commonly used, especially in conjunction with things like vancomycin, for when you have a patient who has a really severe infection, but you don't know what it is, and you want to go with really broad empiric coverage. And so 3 drugs that fit into this category include amikacin, gentamicin, and then tobramycin. And so, again, these are sort of bread and butter gram-negative coverage. And so this is kind of similar to aztreonam, which we saw last week here, but this only really works for gram-negatives, right? Has really good Pseudomonas coverage. Will cover just about every other gram-negative out there, but doesn't really do much in terms of anaerobic coverage or gram-positive coverage. Okay, the only gram-positives you're ever going to see gentamicin or other aminoglycosides being used for is if you're using it for what we call gram-positive synergy, and that's something that we'll talk about in the cardiac section a little bit later on, where sometimes it can help by using it along with something that does work in gram-positives can get a little bit better kill, but we really only use that for like endocarditis, and it's pretty rare. So think about this one as mostly just gram-negative coverage. And so, as I mentioned before, if you have one of those patients coming in, say like from the nursing home, and you know they're really high risk for having pretty resistant infection, but you're not sure if it's what it is. Is it MRSA? Is it Pseudomonas? You kind of have to go with the worst case scenario, and so you go really broad spectrum. And so this is a case here we're going to use like something like vancomycin for MRSA coverage, and then you're going to use something like aminoglycosides for the Pseudomonas coverage. And most frequently, we actually end up using 2 drugs to cover for Pseudomonas, just because you want to make sure you get something that's going to actually cover it. And so it's not uncommon to see a patient on like a 3-drug regimen empirically on vancomycin, gentamicin, and say for instance like Zosyn or cefepime. And then once you have your cultures back, then you can go ahead and scale things down to see if it comes back and it's just MRSA. Well, I don't need anything to cover Pseudomonas at that point. So the using these broad spectrum drugs is handy at the offset, but make sure you're scaling back and getting rid of these stuff if you don't need it, right? You don't want to keep any drugs around on a patient's profile just because it makes you feel better, right? You want to have a good reason for it. And so this is another example, or kind of one of the first main examples here of a concentration-dependent killer, which I think is a good example of this. So back in the day, we used to use like traditional 8-hour dosing, Q8-hour dosing for the aminoglycosides. But nowadays, we realize due to that post-antibiotic effect, we can just give one-time daily doses. Give one big dose a day. That's generally going to be enough to kill off most of the bacteria in those patients, even if the levels drop down to like nothing. Right? So I'll show you some pictures of what that looks like in a moment. Anyway, very good for like sepsis, for febrile neutropenia, patients who are immunocompromised. And in terms of organ toxicity, this should look pretty similar to vancomycin. You do want to worry about renal toxicity and ototoxicity, and that's why we again have to watch our levels. So this is kind of the second set of drugs. So vancomycin needed therapeutic drug monitoring. This is the second set out of the bunch that also requires it. Okay, and so just to give you an example of what that looks like when we're doing our levels here. When you're doing therapeutic drug monitoring on something like vancomycin versus aminoglycoside, you got to think about what you're doing it for in a lot of cases. So let's say we're looking at our concentration versus our time on the x-axis here. We have the MIC for a particular bacteria. With something like vancomycin that's being used, say for instance, like every 6 hours, because it's a time-dependent killer, you can see here is that you want to be dosing it as your levels go up. As you hit steady state, you'll get this nice pattern here. And again, when you're doing therapeutic drug monitoring, you're checking the troughs here because one, you want to make sure that the level is high enough to be above the MIC and then not so high that it's going to cause toxicity. What it would look like for something like an aminoglycoside, though, is you'd have just one-time daily dosing here where it goes up really high and then it trends down, right? Give another dose and then it goes back down. So the point here, though, is that we still check troughs, but we're doing it for a different reason. With the vancomycin, we did it for both therapeutic efficacy and toxicity. Here, we want to make sure that it's undetectable. We don't even want to measure a level at the trough point because we want to make sure the body's actually clearing it out. If it was up any higher than this, then that would predispose the patient to having nephro and ototoxicity there. We know the peaks are going to be high because we gave such a big dose. I don't have to actually check this level. I'm just checking the trough to make sure that I'm not having any accumulation happening here, which can predispose them to that toxicity. That's kind of the big difference in terms of how we're using therapeutic drug monitoring between something like vancomycin to the aminoglycosides. So getting back into this again, we're checking, make sure you're checking those troughs there. Usually we're looking for those to be undetectable. So when the lab reports that out, it'll say not detected or something like that. And that's typically what we're going for there. Okay. So then switching it up and going into another good gram-positive killer, we have linezolid here, or Zyvox. And so this is kind of the drug you use if vancomycin is found to not be appropriate due to resistance, right? Or if a patient has such a sort of labile kidney function to where vancomycin is not going to be a very good choice for them, this is where we're going to bust out the Zyvox for those patients there. They're really good for like multi-drug resistant gram-positives like MRSA, VRE, no gram-negative, no anaerobic coverage for those, right? So kind of the big difference you'll see there between something like Zyvox, which is still a protein synthesis inhibitor, versus a lot of other ones you're going to see out there. In terms of toxicity, you can see some risk for thrombocytopenia, so you do want to watch out for like bleeding risk and watch that CBC for those patients there. And then also, there's something that's interesting is it has an interaction with a lot of medications that we use for depression and anxiety. So if you ever hear of an SSRI, it stands for selective serotonin reuptake inhibitor, and that's something that we use to increase serotonin levels, and that causes some changes in the neurochemistry that leads to decreased symptoms of depression and anxiety. And so anything that increases levels of serotonin has a chance to interact with this drug Zyvox and lead to really elevated levels of serotonin, which all things are good in moderation, but when too much of a good thing can happen there, you can get what we call serotonin syndrome. I'm not going to go super in depth on this right now because we're going to talk much more about this next semester when we get into the psych drugs. Just know that serotonin syndrome is something you typically want to avoid. And if a patient's on something that is increasing serotonin levels like an SSRI, if you mix that with Zyvox, their chances for serotonin syndrome is going to be elevated. So just be aware of that. Anyway, so sort of in that same ballpark in terms of coverage for really resistant gram positives to vancomycin, we also have another drug called daptomycin, otherwise known as cubicin. This is a different mechanism entirely from Zyvox here, but basically what it does is it depolarizes a bacteria, basically disrupting its DNA, RNA, and protein synthesis. Really bactericidal, really good at killing off those bacteria, but again, it's only going to work on like gram-positive bugs. That's pretty much it. What's interesting about the difference here between Zyvox and daptomycin is kind of what the indications are going to be for it. Whereas Zyvox you can give for pretty much any gram-positive infection, no matter where the site is. Daptomycin is limited into where it can actually work. It actually does not work for pneumonias because the surfactant in the lungs actually disrupts the drug and prevents it from working. So it's kind of interesting. They can use it for like skin and soft tissue infections. You can use it for bloodstream infections. You can't use it for pneumonia. Um, one thing you'll see with daptomycin, because it does cause depolarization of these cells, there is a little bit of bleed over effect and affecting our cells as well, and that can actually cause some muscle toxicity. And so patients will complain of myalgias most commonly, and you definitely want to measure those CPK levels, which some people will call it California Pizza Kitchen, which I did not know about at the time. But no, this stands for creatine phosphokinase. This is an enzyme that is leached from the muscles when they start to break down. You'll see very elevated levels of that when you have something like rhabdomyolysis that can help. So if you see that, you'd want to go and discontinue this drug and use something else like a vancomycin or Zyvox. All right. Up next, we have fluoroquinolones. So that was kind of the main set of protein synthesis inhibitors we were just looking at there. Daptomycin, again, having a different mechanism. Next off, I want to talk about the fluoroquinolones. And so these are the main three we'll talk about here. We'll see there are others as well, especially when we get into like our ophthalmology drugs and like that. So here we have levofloxacin, ciprofloxacin, and then moxifloxacin. At least here, the naming convention is pretty easy to tell if it's a fluoroquinolone or not. So basically, how this is going to work is it's going to inhibit an enzyme called topoisomerase. And so what does topoisomerase do? Well, normally when you have DNA in its sort of storage form in the cell, it's very tightly wound. It's not really easy for many enzymes like DNA polymerase to work on it. And so what happens is you have topoisomerase will come in and sort of induce these single or double strand breaks here in the DNA that allows it to unwind and allows it to be read by different enzymes. And so then on the flip side, when it's going to wind it back up, then it will cause, again, those strand breaks to occur, and then we'll reseal them. So it's kind of like, cutting a piece of string and then scotch taping it back together over and over again. So this is a really important process here. If you disrupt this, then the DNA will start to include more errors. You'll start to see more strand breaks occur here that are not repaired, and that leads to eventual apoptosis, right? Just there's enough damage to the DNA where the cell says that's it, get rid of it entirely. And so this is going to be the main mechanism of the fluoroquinolones. We'll actually have some drugs that will do the same thing for human cells that we'll end up using later on in this class here. So, getting into the fluoroquinolones, they kind of have similar coverage to what you might see with the tetracyclines and the macrolides to some degree. And so you'll see them used pretty interchangeably for things like CAP and sinusitis and things like that. However, you are going to want to try to hold off on using these if possible due to a lot of resistance. It's pretty easy to use these drugs, and that leads to overuse, leads to a lot of resistance happening here. So, also some collateral damage in terms of tissue, organ tissue toxicity we'll see here, and then also C. diff infections are a little more likely. Now, we like these as well because for the most part, they tend to have pretty good Pseudomonas coverage as well. So when I talked about having that double coverage for Pseudomonas, those cases there, you could use something like gentamicin plus levofloxacin, or you could use something like cefepime plus ciprofloxacin in some cases. So again, make sure that whenever you're using double coverage or using two drugs to treat the same bacteria, that you're using complementary mechanisms. It wouldn't make sense to use carbapenems plus a anti-pseudomonal penicillin together because they both work on the same site, same binding sites, and so that would not make sense to combine those. However, using carbapenem plus a fluoroquinolone makes a lot more sense because they're working together instead of at the same goal there, right? Or at the same targets. So that's why you'll see these used in combination occasionally. Now, one thing to note here is that UTIs, you do not want to use moxifloxacin for that because moxie is the only one out of this group that actually is metabolized entirely in the liver and does not get any particular levels in the urinary tract. And so if it doesn't ever go to the urinary tract, it's not going to treat the infection there. All these other ones we're going to look at are going to be mainly renally eliminated. So again, watching for renal function and adjusting the dose based off of that's another really important thing. Okay. So this one has some generations. You won't hear it talked about as commonly as you will with like the cephalosporins, but and we'll see some of the first generation ones when we get into some stuff like in the ophtho section. Talk about that, or otitis media and things like that. When we get into ENT later on, we'll see those pop up there. But anyway, so we have our second generation fluoroquinolone. Ciprofloxacin is going to be the main one in this category here. Here it has pretty good gram-negative and atypical coverage, which is why we like it pretty well for, and it gets things like strep pneumo and whatnot. So it has pretty good coverage for things like upper respiratory tract infections and things like that. Questionable Pseudomonas coverage. I probably wouldn't use this as like first line, but it may have some benefit there, especially if the bacteria is cultured and is found to be sensitive there. Again, renal dosing considerations, make sure you're adjusting based off of that. Next we have levofloxacin. This gets even better gram-negative coverage, and you're going to see better gram-positive coverage and pretty good pseudomonal coverage. So this is kind of a good go-to medication, especially for like community healthcare acquired pneumonias. Has good pseudomonas coverage for those particular patients. However, especially for like a lot of community acquired pneumonias where strep pneumo is more common, you are starting to see more resistance to this. So that's where you'd have to see where you're working at in a location sense and see what kind of resistance patterns are happening there. Because whereas something like levofloxacin may be a good one for community acquired pneumonia in Florida, it may be bad if you go work somewhere else where there's higher resistance patterns there. So one thing to consider. I mentioned moxifloxacin. Not great Pseudomonas coverage here, and then again, you can't really use it for UTIs because it gets metabolized in the liver. However, this one would not require any renal dose adjustment. So depending on the infection site, this may be a good option for your patient, especially if they have like not really great kidney function. So in terms of side effects here, this is another set that's going to complex of cations, very similar to the tetracyclines like I mentioned before. So you may want to make sure they're not taking this with calcium or with iron-containing products. Again, can be challenging, especially for like older patients who drink a lot of milk for osteoporosis concerns, so watch out for that. Some photosensitivity, CYP interactions here with that inhibiting 1A2. They're not as clinically important as 3A4, but, and so, less likely to cause significant drug interactions like you would see with something like erythromycin, but still that can be a risk there. So again, you want to look this stuff up. Most of them require renal elimination, so you do have to adjust that. You may have to go from like Q12-hour dose and Q24-hour, depending on the kidney function. And then this is another set similar to the macrolides that can cause QT prolongation. So the risk for torsades is going to be higher. Normal QTC, depending on if you're talking about a male or female patient, usually between like 440 and 460. Once you start to get above like 500 milliseconds, that's where you start to really worry about the risk for torsades for those type of patients. And again, fluoroquinolone by itself is probably not going to cause torsades unless the patient has some pre-existing or predisposing factor. So prolonged QT due to heart defects, due to electrolyte abnormalities, anything like that. Now, another unique thing you're going to see here is actually this tendonitis and the propensity for Achilles tendon rupture that can happen here. And we see this more frequently in children, so we try to be judicious about when we use the fluoroquinolones in kids less than 18. It's not to say we never use them, but we try not to unless we really have a good indication to do so. And if they start to complain of like tendon pain, things like that, then we definitely want to consider stopping the medication there. Not a good mechanism for why this occurs. We just know there's more likely to happen in kids there. Okay. And also in CNS toxicity, this is sort of unique to the fluoroquinolones. Sometimes, especially in older patients, it's difficult to tell. Is grandma or grandpa, is their dementia getting worse, or is it because they have an infection, or is it because they have a medication on board that's causing some degree of toxicity? And so this can be one of the things you may want to be watchful for in older patients. Next up, we have clindamycin or Cleason. This is actually another a protein synthesis inhibitor, but it's kind of unique in how it acts. So I kind of break it off from the other ones here. This one has a pretty interesting set of coverages. Okay, so Mina, I think it's Mina, not Mina. Correct me there if I'm wrong. Is it contraindicated to use a macrolide with a fluoroquinolone because of risk of torsades? Yeah, I would. I do not know of any particular indication where you would use a macrolide and a fluoroquinolone. There might be a case for it out there. I'm just not aware of it. But again, I'm not specifically an infectious disease person. It would be very odd to ever see that combination. So it would be a relative contraindication to use the two together. Now in situations like that where you have to use two drugs that have a known risk for causing QT prolongation, what do? Well, you go ahead and you can start the drugs on them together. You can do a baseline EKG to see kind of what their baseline QTC is, and then you look to see once you introduce the drug how it sort of change. And so if you see a very significant increase, and again, significant for one provider may be different than another, then you may consider stopping it, trying to use something. But that would be very odd to use that combination. More often, what you find is you will have a patient. Here's a good example of one where one time when I was on rotations, we had a patient who was in the pediatric ICU. She had very severe leukemia and had just received a bone marrow transplant. And so, in order to do that, you have to basically wipe out all of her own bone marrow and then introduce else's. And you have to put the patient on immunosuppressants for that in order to make sure they don't reject that new bone marrow. So, she had a suppressed immune system due to the cancer treatment she was receiving, due to the bone marrow suppression she had, immunosuppression she was receiving. And so, when you suppress the immune system that severely, your risk for infection goes up pretty significantly. So she ended up having severe viral and fungal infections. And so she ended up having to be on immunosuppressants to prolong the QT. She was on antifungals to prolong the QT. She was on antibiotics to prolong the QT. And so that was when we had to do like daily EKGs on her to make sure that one, her electrolytes were going to be in check. Looking at Kim7, and then also looking at EKG to see it did not get too prolonged. So monitoring was very strict for her, but she's in the ICU where that could happen more readily. So anyway, in terms of clindamycin here, how we're going to be using it, it's going to be great for gram-positive coverage, a really good MRSA coverage for the most part. This is also going to be good for anaerobes, both gram-positive and gram-negative anaerobes. This is not going to be good for gram-negative bugs, gram-negative aerobes, I should say. So, if you had someone who had, say, for instance, like a gut infection, intra-abdominal infection, you could use clindamycin for the anaerobic coverage, but you would need something else to get the gram-negative there, right? This is going to be better off for things like skin soft tissue infections. Clindamycin is good because it actually binds to exotoxins. It can be released in things like toxic shock syndrome, things like that. So, interesting use case here. You'll see this probably used most often for like skin soft tissue infections and abscesses and things like that. Now, because it has good anaerobic coverage, it does have a tendency to wipe out the gut flora, and so your risk for having C. diff is actually one of the highest clindamycin. So that's definitely one thing you want to know there. And again, severe C. diff infections can actually end up leading to pseudomembranous colitis. So that's kind of an evolution of that infection there, leading to severe inflammation of the colon. So you want to watch for that. Katie's saying, is clindamycin still considered a DNA inhibitor as far as it is MOA? Now, if you go back and look, it's still a protein synthesis inhibitor. So fluoroquinolone's working on that topoisomerase, but clindamycin's working on the actual proteins to kind of break it off itself because its activity is so different than a lot of the other protein synthesis inhibitors. So moving off onto sulfamethoxazole and trimethoprim. So most of you probably heard of like Bactrim or Septra before. This is pretty commonly used for things like UTIs, especially for like uncomplicated UTIs. This is interesting how it works because it always comes as a combination set of drugs here. And basically what it's doing is inhibiting the utilization of folic acid in the bacterial cells. So you say, okay, what's that going to do? Well, you need folic acid to be utilized in order to form things like tetrahydrofolate, which is utilized along with things like thymidylate synthase in order to produce new nucleotides. You can't utilize folic acid to produce new nucleotides. You can't produce new DNA. So that eventually leads to enough errors in the DNA itself where it basically, again, triggers off apoptosis. And so by using sulfamethoxazole and trimethoprim, both working in different steps of this process here, you end up finding that helps get better overall inhibition of this process here. So if even if one was a little more resistant, the other one would kind of pick up the slack there. But very good from that standpoint. Pretty good coverage in terms of being pretty broad spectrum. No anaerobic coverage to speak of, but it does cover MRSA. It gets things like strep pneumo. It's going to get things like Moraxella catarrhalis. We oftentimes will use this for a lot of sort of opportunistic bugs, things like Burkholdia cepacia and Stenotrophomonas multifilia. But you know, we end up seeing this used for a lot of things like skin and soft tissue infections. We use this for a lot of UTIs and things like that. Also interesting, you can also see this being used for a lot of opportunistic infections, patients with, for instance, like AIDS, or if they have severe immunosuppression due to things like cancer treatment. So things like pneumocystis, nocardia, and toxoplasmosis can all be treated with Bactrim. Pretty good drug. Again, you're going to see it used all the time. Again, here's some indications we're going to be using this for. Again, respiratory tract infections, GI infections, GIs. It's very broad spectrum, so you're going to see it used pretty much a workhorse for most of your patients there. In terms of adverse effects, we're going to see that, of course, nausea, vomiting, diarrhea, always going to be a risk with any of these here. The hypersensitivity, this is an important one. Do want to be cautious here for any patients who develop new rashes, or if they develop like ulcers in the mouth or any kind of like blisters and things like that, because this could be a risk for things like Stevens-Johnson and toxic epidermal necrolysis. And so this risk for it and with Bactrim is a little bit higher than you're going to see in many other medications. So you do want to watch out for that. Now, because it's inhibiting folic acid utilization in bacteria, it's pretty selective for that, but it can have some crossover and actually affect us as well. And so this is where you can see some bone marrow suppression here, things like thrombocytopenia, granulocytosis. These are pretty rare, but you still want to be watchful for that, especially if a patient's complaining of any like worsened infection. It could be related to this potentially, or new, something like that. In terms of drug interactions, you can see some significant ones here. So for instance, we talk about warfarin in terms of anticoagulants. This has a strong CYP2C9 inhibition, which can lead to very high levels of warfarin, which can lead to bleeding. You can end up seeing here that it can also affect things like clearance of methotrexate, which we'll talk more about like in the cancer and rheumatology section later on. Can worsen hypoglycemia when used with drugs for diabetes. So a lot of interactions here. This is another one you definitely want to check the profile for, just like with your macrolides. Check the profile, make sure you're not going to cause any significant interactions. Yeah, Joshua Evans is saying, when studying these antibiotics, would it be better to know what diseases they specifically cover, or should we know the bacteria species they cover as well? Good question. What I'm trying to do in this section here is trying to expose you to sort of how we're using these drugs, why we're using them, just so you sort of get start off your understanding of this topic. Based off this set of PowerPoint specifically, am I going to ask you, what the treatment of choice is for toxoplasmosis? Probably not, right? When we get to that section, we talk about treatment for opportunistic infections and HIV and AIDS. Yeah, then I'm going to ask it there. Or if I'm talking about what's the best treatment for CAP, we'll talk about that in the pulmonology section. trying to get you kind of sort of seeing this stuff so you can start getting an idea of like, okay, when I say covers gram-positives, like what am I really talking about? So notable exceptions to that, though, are going to be things like MRSA, Pseudomonas, C. diff. Something covers atypicals or not. Something covers anaerobes or not. Those are kind of the more broad sort of things I'll be potentially asking about. You might see like on a quiz or on a test coming up. So don't get too hung up on the details in here of like specific bacteria, unless I mention it as being one of those particular ones like Pseudomonas, MRSA, things like that, because those are really big ones you want to certainly know. So hopefully that helps a little bit in terms of figuring out what. Okay. So up next we have Flagyl, which is going to be metronidazole as a generic name. This one's going to be working on bacterial DNA synthesis, basically kind of messing up its helical structure there. And so this one also has pretty interesting coverage. Really, this one is only used for anaerobes here. And so gram-positive, gram-negative anaerobes, parasites as well. So you can see this for certain vaginal parasitic infections. And so this is a common one you'll see sometimes by itself, but oftentimes we'll use it in combination with other things as well. So, for instance, if I have to use this for an intra-abdominal infection, I would need to use this with something else that covers gram-negatives and positives. So, for instance, I'll use something like metronidazole along with something like ceftriaxone, like a third-generation cephalosporin or something. This is also the other main treatment for C. diff. And so, whereas with vancomycin, I can only use oral vancomycin for that, here you can actually find you can either use IV or PO. And this used to be the gold standard for adult patients, but because of increasing resistance patterns to it, that's where vancomycin is now a little bit more common to be used there. It's kind of the first line now for adults. Christine is saying, are we expected to know what is atypical or just which drugs cover atypicals? I would more expect you to know that the drugs cover the atypicals, but this is where you want to start to kind of be thinking about these and being like, okay, what are the common ones? Things like Legionella, things like Mycoplasma. Those are the big ones you're going to be seeing here most commonly. So start to make those associations. But I would give you like on a test question just based off of this PowerPoint, right? Not if we get into the specific like organ system on, by say, okay, you're worried about an atypical pneumonia caused by this bacteria, which of these drugs is most likely to cover it? And you wouldn't necessarily need to know that specific bacteria, but if I said atypical, then you would say, okay, well, I know like, the tetracyclines can cover that. I know that, the quinolines can do that. I know that the macrolides can do that. And you'd look for one of the drug choices to be one of those classes, right? That's kind of how you would kind of think about it. So, other things you'll see with metronidazole is that it actually causes what they call a disulfiram reaction with ethanol. And so ethanol, as you know, is in a lot of your alcoholic beverages. And so this is an interesting reaction where it actually helps to block the breakdown of one of the metabolites of ethanol. Ethanol kind of is like a two-step breakdown process where it turns into something called acetaldehyde. And there's an enzyme called acetaldehyde dehydrogenase, which will actually break that down. What happens here is that metronidazole can block the activity of acetaldehyde dehydrogenase, so the body is going to build up levels of acetaldehyde. That's a really irritating chemical to the body, causing a lot of like, nausea, vomiting, cause a lot of flushing. Patients feel very hot. It's just very not a good feeling here. So definitely watch out. Do not combine metronidazole plus ethanol because you can see those reactions there. Disulfiram is actually a drug that we sometimes will use for alcohol disorders to try to prevent patients from drinking alcohol in order to prevent that reaction from happening. And so that's it for this section. Let me know if you guys have any questions on that one. You can post it up. Otherwise, I'm going to move on to the next PowerPoint here. Dermatology. Pick the sticky board. All right. Someone asked, "Do you want us to learn a specific indication?" More general, based off of that PowerPoint. Again, I'm just trying to get you exposure. You can start to see it, start to think about it. When you hear about it in other classes, just start to have some connections there you can start to make, right? How would we know if there is antibiotic resistance? Do we just see it on a culture and sensitivity, or would we see no improvement on a patient's condition? Yes. So some things you can see with that. So, not every single disease state we necessarily do a culture for. So, for instance, if I have someone come in for an acute otitis media, you're probably not going to culture that, especially if it's like the first time they've ever had it. I'm not going to sit there and try to puncture through the tympanic membrane to get a culture of that. You just don't do that unless the patient has like recurrent disease or very severe disease. And so you start them off on broad spectrum coverage. Say I start them off on amoxicillin, but it's 3 days later and they have no improvement whatsoever. That could be a sign of resistance and could lead to me choosing to up that coverage to a different drug, right? That's one way. Or in a lot of cases, if you're doing something to where patient gets admitted to the hospital, you've done like they're being admitted for pneumonia, and you've done a sputum culture, and then it will show resistance there. Then you can say, okay, I want to go ahead and switch out these drugs to something else that is sensitive, right? So maybe your patient's been improving, maybe not. Just depends on the situation, but sometimes it's either or it could be both. It just depends on the situation. It's a good question. All right. So moving along, then we're gonna talk about dermatology. So talk about some introductory material for dermatologic pharmacology. Now, I will tell you that no practitioner is an expert in everything, and to say that I know everything about every drug ever made would be a gross overestimation of my abilities, and I do not claim to make those kind of claims there. Or to claim to have that knowledge. And so, there's some things I'm like stronger on or weaker on. Like if it comes to like, toxicology stuff, emergency medicine stuff, I'm pretty good with ID stuff. I can answer a lot more questions on that sort of thing. Like some things I'm just not as familiar with because I don't run into it as often. Or if I'm just not like super interested in it. So like derm stuff, I'll talk about kind of the basics here. And I know a lot of you may be interested in like practicing derm. So it's one of those things where like, it's just not a big passion of mine. So I'll get to the basics here. But in some cases there you may have questions that I may not have the answers to. And so we may need to do some extra research there or, go through and try to find the right answers. There may not be any good answer for some of your questions, but just FYI, again, I'm not going to be the guru on every single thing we cover here, but it's probably a safe assumption I probably know a little bit more about dermatologic drugs than you do at this point. So I can at least give you the basics here and make sure you're well equipped to where you cover this stuff in your medicine course, you can at least have a good handle on the drug topics there. So anyway, so let's talk about some of the variables that go into pharmacologic response to topical medication. Anyway, the whole point of that thing was basically say I don't know everything. I'm fallible, and so it's important to we can question that. We can if you have questions I don't have the answers to, we can look stuff up. So and any teacher says they know everything, I'm not a very good teacher. Anyway, getting into this, we're going to see that in terms of like pharmacologic response to topical drugs, a lot of it is very dependent on several factors. Some of it has to do with patient factors, some of it has to do with the actual drug factors itself. So, for instance, drug penetration is very different depending on where you're applying medications. So, for instance, thinner skin is going to have an easier time for drugs crossing over than thicker skin, just like we talked about in the summertime with Fick's Law, right? Things that have thinner membranes have more flux, have more ability for the drugs to cross over than things that have areas of thick skin. So, like, the axilla, face, scrotum, things like that have an easy time for drugs crossing over as compared to, say, the soles of your feet or something. Now, again, we're talking about dermatologic stuff. We're not talking about all transdermal medications. We're mainly focusing on medications used to treat dermatologic conditions here. So I just want that distinction. We'll talk about other topical medications elsewhere, but it'll be more in specifics to how they work for hypertension. Now, other things too, including concentration gradients. So the higher the concentration, the more drug is going to transfer as well, right? Because remember, the difference in concentration gradients between the inside and the outside of the membrane is really important. There's some more drug I have on the outside, the more it can kind of force its way across just due to natural diffusion there, right? So increased concentration, increased drug transfer that can happen there. So for instance, if I had someone who's having, say eczema or something like that, it really wasn't working all that well, I could try to increase the potency of the steroid by increasing the concentration, and that can then lead to better effects. Okay, so concentration can make a difference there. In terms of dosing schedule, you're going to typically see that for many medications, especially topically administered ones, you do have to administer a little more frequently. So like, Q8-hour dosing, 6-hour dosing. But in some cases, it's actually kind of nice because the skin acts as sort of like a reservoir for the drug. So we call that a depot effect. If you ever see that, I say like a depot, just like a Home Depot is like a storage spot for a ton of housing items. You get this depot effect in the skin to where even if I was to say, giving a topical medication for like a week or two, if I were to discontinue it, you could still see continued drug effects because of the fact that that skin has built up a storage of it, a depot of it. And so that can be helpful in some cases because that may allow for just like once daily dosing. Medications are very short acting, or even if a patient misses a dose, you're not necessarily going to see the drug effect drop off entirely, just that one missing dose there. Next thing here is talking about vehicles and occlusion. When I say vehicles, I'm not talking about the car that you drive or may not drive due to social distancing isolation, but it refers to what the actual drug itself has been put into. And so I'll talk about a few different agents there, but this is talking about whether it is put into like a lotion or an ointment or a cream. All of those mean different things in terms of like water content, in terms of other things that it's suspended in order to cure that drug, put it on the skin, and let it do its thing. Occlusion is also a term here where, just like as you might imagine, things that have high occlusion, they stick around for a long time, and they are able to have greater drug contact for a longer period of time, which usually means greater efficacy there. But that can also mean toxicity as well. So we're going to see occlusion can sometimes be a bad thing if it leads to too much drug being transferred through the skin there. Now, the vehicle itself can really affect drug permeability in terms of whether the drug is hydrophilic or lipophilic. Not only that, but the vehicle itself can have either moistening or drying effects. And so one of those general rules of dermatology you always hear, which, works well enough, but, if you ask like a true derm person, they'll probably say it's not right. They say, in derm, if it's wet, you got to dry it out, and if it's dry, you moisten it. And so the vehicle can make a big difference here. They can have a big effect on either having a moistening effect or drying effect, as we'll see here in just a little bit. And oftentimes the vehicle itself may be therapeutic, right? So if you have someone who has eczema and the skin is like really red and inflamed, the vehicle itself, like a nice lotion or an ointment, may help to kind of soothe the skin in and of itself and be beneficial. There's that. So when we're picking the vehicles that we're going to put our medications into, we have to consider like what the solubility of the drug is in the vehicle. And so if the drug is not soluble in the vehicle, then it's not going to work because it's not going to really stay in solution there. And then again, the ability for the vehicle to hydrate that stratum corneum. The more hydrated that is, the easier it is for that drug to penetrate through that skin, which makes sense if you think about, kind of hard, scaly skin being more difficult to penetrate than something that was nice, soft, and right. Also, the other big thing too is that anytime you have a drug that is in water or anything that contains water, you have to think about the stability of the drug in that vehicle. So not only is a drug the actual molecule itself how stable it is, but also we have to start to think about things like sterility and like are we increasing the risk for things like bacteria to start to grow in that product, which could lead to infection, right? And so here's kind of a general scale of things in terms of things that are most drying up here at the top, which is better for things that are like like oozing or crusting. They have like vesiculation. Things are very moist. And down here to things that are more drying. So if you're having like a scaling or lichenification, things like that, these are going to be things that are going to be least drying or they're going to be the most hydrating for the skin there. So you can see that goes down from tinctures and things that contain alcohol tend to be very dry because that alcohol will evaporate and take some water with it. Down to where you see like lotions and aerosols and powders and things like that tend to be more drying. Then down to when you get to like paste and creams and ointments, these tend to be these drying, a little more hydrating in a lot of cases. You're also going to see that the occlusion is going to go up as you get to things that are less drying as well. So like ointments tend to have the highest occlusion, whereas lotions would have much less occlusion to that as well. So this is a handy slide here to kind of compare some of the more common sort of vehicles you may have your drugs being dissolved in. And so just to give you an idea of what the right kind of physical basis is and some of the other factors here, I wouldn't necessarily memorize this entire, you know, chart here, but I think some of the things can be important. So for instance here, like a cream is going to be more so an oil and water emulsion, where it's going to have a higher water content than something like an ointment, which is going to have a more water and oil. And so you may look at that and you're like, wait, oil and water versus water and oil, what the heck does that mean? It has to do whatever has like kind of the greatest content. So for instance, if it's oil and water, well, water is going to be the more prominent sort of component there versus water and oil. is going to have oil is going to be the sort of higher content. So this is where, like in ointments, if you've ever applied like a lotion versus an ointment, you kind of know the feel of them are a little different. Ointments, they stick around for longer, they stick on the skin, they have kind of that greasy feel to them, which can be okay in some cases. It can be useful, especially if it helps to keep that drug around for a longer period of time. But most patients don't really like that feel. You need soap and water in order to get rid of it and all of that. And so that can be a difference there, but it can be protective. Kind of the benefits, it sticks around for longer there. Versus something like oil and water emulsion, having a higher water content tends to wash away with just water a little bit more easily there. Can leave some drug concentration on the skin there, but again, most of the time once it's washed away, it's usually it's going to be there. But it does spread and move a little bit more easily. No greasy feels compared to an ointment, right? Usually, in terms of like ointments, because they stick around for longer and have higher occlusion, you want to avoid some of the intertriginous areas like the axilla, the groin, things like that. You want to avoid because you can see increased uptake of those drugs in those areas with that kind of thin skin, high occlusion, where it's kind of skin on skin contact. A lot of times that can lead to a lot of absorption cases there. And then in terms of things like gels and foams, again you're going to find that especially with lotions have much higher water content, and especially like with foams and gels, they can have alcohols included with them, which can lead to drying effects as well. So if the skin's already particularly dry, this may not be a good option for them to use high alcohol content. All right. So enough about the basics of that. I want to get into talking about some specific topics here. So let's talk about acne. First off, acne is it's a difficult condition because there's so many different factors that go into it, whether it be genetic, can be some hormonal effects, can be dietary, a lot of different things there. But in general, what we're going to see in terms of the pathophysiology is we're going to have four main sort of processes here going on. First off is going to be this increased sebum production in the follicles. We're going to see. I'll show you some pictures of this in a moment. We're going to see some alteration in the keratinization process, and you end up getting this hyperproliferation of the ductal epidermis. And we'll see that's going to cause kind of a blockage of those follicles and leading to sebum production kind of happening here. And now it's closed off to it. Now you have this nice anaerobic sort of environment where some anaerobic bugs can start to grow. And this is where we're going to see knowing what kind of coverage that your different antibiotics are going to have can lead you to choosing certain ones to cover likely bacteria that are causing disease, right? So anyway, they had this bacterial colonization with things like Propionum bacterium acnes, which is going to be an anaerobic gram-positive here. And then as a result of that, your body's going to start to react to that and increase this inflammatory response. You're going to see that's where you get a lot of that inflammation, a lot of that pus that forms is due to things like macrophages and neutrophils coming in and starting to chew up those bacteria, spit them back out, and that's how that nice bit of pus develops there. Some other factors can go into this, things like your environmental causes, heat, humidity, inducing some of these comedones from forming. You can have things like shoulder pads or helmets, especially for like teenagers who are more likely to develop acne. If they have things like helmets and whatnot forming in sports, that can lead to that. Even things like the season can affect this. So things like the winter time being a little bit worse than being in the summertime, and then just looking at things like physiologic stress, increasing glucocorticoid secretions like cortisol, because you're chronically stressed out, either because you're a teenager, because you just started PA school, can lead to suppressing that immune system, right? So that can lead to some of the bacteria continuing to grow a little bit more, and can lead to worsening acne for some, right? So a lot of factors that go into that. Again, here's kind of what we were talking about before in terms of those four processes here, where again having that pooling of the sebum, those anaerobic conditions helps to lead that Propionum bacterium acnes really kind of get out of control and really start to colonize those little areas there. Again, the body's responding to that. It's going to be increasing that inflammatory response to that. Also, you're going to see that bacteria themselves are starting to hydrolyze some of these triglycerides into free fatty acids, further lead to that keratinization there, and overall cytokine formation and whatnot are helping to generate that pus that you typically see in a lot of those lesions. And again, you can see that it can be more or less non-inflammatory, as you're going to see here, whether you have the open and closed comedones, more non-inflammatory causes, or inflammatory kind, more kind of nodular, papulopustular kind of lesions you'll see there. Fortunately for our purposes, though, treatment is going to be pretty much the same between them, as we'll see here in just a little bit. Again, here's one picture kind of showing you the processes are going in. I think the next picture here is probably a little bit more illustrative, to where you can see the hair follicle itself. Here's the sebaceous gland producing that sebum. Notice here how it's causing it to be occluded, starting to become anaerobic, and that's allowing the bacteria to grow, and then that's causing the inflammation cascade to occur there. And a lot of this tends to sort of cycle back in and on itself to cause even worsened inflammation over time. So, um, I also like to talk about a lot of cases too when we have disease states that can be caused by medications themselves. I think it's important, when you have a patient who comes in who's complaining of something new happening, not just to look at just the strict disease states that may have developed that has led to that complaint, but also look at which medications it might be on that is also worsening that, right? Because there's nothing worse than having a medication reaction happening, and then you have to treat that with another medication. Then maybe that medication causes a side effect, so then you treat it with another medication. So this is something you're going to see a lot with, especially patients who see multiple providers, where they're not necessarily communicating with one another, and they just see their medication list. The patient just blows up. And so if you can identify a drug-induced cause, this is really handy because you can either try to get rid of that drug, change them over something else, or try to at least identify it to make sure you know that that's what's causing the issue. So, in general, I think fewer drugs used for patients is overall better for them. Even that means less job security for me, I suppose, but it is what it is. So in terms of drug-induced acne, some things you can see is being more likely to cause this. Systemic corticosteroids are very common here. When I'm saying systemic corticosteroids, I'm talking about things like prednisone and dexamethasone and things like that. Again, they're suppressing the immune system, and so this is where you can see that even though themselves are used to treat inflammation, you're going to see that it can allow the bacteria start sort of to grow on their own and lead to the immune system not really being able to deal with it due to the suppression here, right? And so this is not something you would see, within a few days. This is more over the course of several weeks. So if you had someone who had, say, like lupus or something like that, who was on long-term corticosteroids due to an autoimmune condition or something like that, this is where you're going to run into this most commonly. And again, it depends on how strong of a steroid you're using. So things like hydrocortisone, which is basically kind of like the cortisol that you produce yourself, is less likely to do this than some of the more strong, potent sort of steroids there. What's also kind of interesting too is that you say, okay, well, this acne is getting worse as a result of corticosteroids. Let's go ahead and just DC it. What actually happens, you can see that it leads to worsening when you stop it, because now all of a sudden you're not suppressing the immune system anymore, and now that can actually lead to increased inflammation. So it can get worse before it actually gets better as a result of this. Lowest dose possible, the shortest time possible, is going to help to prevent that. Other things that can also commonly cause drug-induced acne include things like anti-epileptics, tuberculostatics, that's used for TB, and then even lithium, which is a lot for bipolar disorder. So our treatment here, the goals is, this is a chronic disease. There's no strictly curative therapy in a lot of cases here. But basically, you're going to see that early on, we're going to try to start off aggressive, get any kind of outbreaks under control, and then we'll put them on sort of more maintenance therapy. And so this is a thing where patients will go through hills and valleys, right? And so sometimes it'll be worse, sometimes it'll be better. And so when it gets worse, then you're going to kind of step up your therapy a little bit, and then when it gets better, then you can kind of go back to a little bit more mild therapy. What we're going to find is that a lot of the medications here we're going to see used to treat acne also cause a lot of skin irritation in and of themselves, which is not great. So we want to use the fewest medications, the lowest doses possible, just to keep the acne sort of under control. And then when it gets worse and gets exacerbated, then we can step up our game and kind of go back down to sort of your stable maintenance therapy. So obviously some of the goals here, we want to reduce the number and severity of the lesions. Hopefully we don't have any progressive long-term effects like disfigurement that can occur with scarring and things like that. And obviously help out with the sort of the psychological component of this, because I don't know if any of you had acne growing up as teenagers, but it can be pretty negative to your own self-esteem and things like that. So, so where are we targeting? Specifically, this is going to be the microcomedone where we're going to be focusing on this. And so if we can eliminate that follicular occlusion, that's going to arrest all the other steps of that cascade there, right? So if you can help out with that, that's going to be most beneficial. And of course, we're going to be using combinations of both pharmacologic and non-pharmacologic therapy. Obviously, I'll mention the non-pharm stuff, but I'm going to be focusing mostly on the pharmacologic stuff because pharmacist, that's what I do. And oftentimes we want to use multiple mechanisms of action, right? So we want to make sure you're kind of going at it through different mechanisms that are complementary to one another that can target multiple pathogenic steps, right? So if I can use something that both affects that keratinization and affects the growth of that bacteria, that's going to be beneficial. Okay. For the most part, for more mild to moderate therapy, especially if it's limited to, say, just the face or it's not covering a large surface area of the body, topical therapy is going to be sufficient for most patients. For more moderate to severe cases, or if it's covering a large area of the body, that's where systemic therapy is going to be needed. We're starting getting into oral medications being used for topical disease, right? So anyway, so in terms of non-pharmacologic therapy, cleaning is really important, but it's very easy to overdo it for a lot of patients. A lot of people think, well, cleaning my face one time a day is good, maybe more is better, and that can be true up to a point, but then it can get to be a little too much. Um, and again, when you're using cleansing products, these are normally kind of basic substances, basic in terms of pH. And they're made of surfactant systems. And basically, what they're intending to do is to try to disperse and remove fats and oils from the skin. Just like, if I spilled olive oil and got it on my skin, I want to get rid of that, I would use soap. I wouldn't just use water because it doesn't really disperse fats and oils. So you have to balance cleanliness versus overdoing it and getting a lot of drying and irritation that can occur there as a result of stripping the skin of those fats and oils and whatnot. And so soaps oftentimes are not always going to be the best products here, because once they're gone, once they're rinsed off, they don't really provide any long lasting effects there. And then also you can find that the high pH of a lot of soaps, due to them being pretty basic, can lead to decreased activity of some of the other agents, right? So I'll talk about some of the specific ones that can interact with them and deactivate the drugs themselves. So typically don't wash too frequently. Twice a day is fine. Mild cleansers, don't use it too hardcore often. All right. So getting into the topical therapy, two things to note here is that it only works where it's applied. So again, if I have acne on the face and say on the back, if I'm only applying drugs to the face, it's only going to work there, which seems like common sense, but common sense is quite so common. And again, most of these drugs are going to cause skin irritation. So that means that patients may discontinue therapy early because they feel like the treatment is worse than the disease itself. And in order to avoid that, we can do some things. So, for instance, we can try to start with sort of lower strength products, kind of gradually increase in strength as we go. And we can consider using sort of non-alcoholic solutions. Remember, we said that alcohols were quite drying and that can lead to worse irritation. So, if you can avoid those, that can also be useful here. And recall that most of your patients have probably already tried something prior to coming in to see you. So especially if you're working like in a derm office or something, they've tried all the over the counter stuff, right? So you need to do a good job in terms of getting a history, saying, okay, well, what have you tried so far? What's worked for you? What hasn't? And that can serve as a starting point for what you're going to do moving forward, right? So here is a good slide here. I think it's good. It kind of shows you different pathogenic steps here in terms of how the disease is occurring and where certain medications are going to be working at, right? And so you can see how some of these are going to be working in multiple spots, right? So for instance, like benzoyl peroxide works both on the P. acnes proliferation and on the keratinization, right? So using things that work on multiple steps is going to be beneficial, especially if you're using it in combination with other drugs that work via a different mechanism. It can all help to have a good synergy. So the first thing we'll talk about here is going to be benzoyl peroxide. Again, this is a common over-the-counter product. You're going to see there higher strengths. Typically, you're going to find for over-the-counter products, you'll typically find like one or two strengths available. And when I say strengths, I'm talking about the percentage of the product. And typically, the higher the percentages, the more likely it's going to be an actual prescription-based product they'll have to come and actually get. And so what does benzoyl peroxide do? Well, basically, it's going to penetrate that stratum corneum, then actually gets converted over into benzoic acid. So it transfers from benzoyl peroxide to benzoic acid, and that itself actually has pretty good activity against acne. So you can see how it's dealing with the actual infection. And it has peeling mucolytic effects, right? So again, it's helping out with that keratinization. If it can help out with that opening up of those follicles there, it allows air to get in, and it allows for the acnes again to not really be able to grow quite so well. Very handy there. Typically use low concentrations like 2.5%, and then once daily. And you can increase how the frequency and the strength as you go along, but start low and go slow. You'll hear me say that a lot for various disease states. You know, depends on the situation on when that's appropriate or not. You know, if I have a patient who's coming in who is septic from the nursing home and their blood pressure is like, you know, 50 over 30, that's not really time to go low and go slow, right? But for something like acne, probably not going to kill the patient anytime soon. This is where you can take your time if you know, agreed upon with you in the. But most of the time they've already tried benzoyl peroxide. You can see how they were using it, how often they were using it, what kind of effects they had. Did it work? Did it not? You know, what kind of side effects do they have, etc. And then oftentimes you can see this from a prescription standpoint using combination with antibiotics. So again, looking at the drugs here, we have things like erythromycin, clindamycin. I'll talk a little more about those a little bit later on here. In terms of adverse effects, these are things to keep in mind. One, they can bleach hair, so this can be important if you're using it close, like to the hairline. Can bleach clothes in some cases there, so make sure, you know, if they're putting on at nighttime or something, not to, you know, wear their favorite shirt or something, because that can lead to issues, you know, where they're applying it. And then, of course, skin and mucous membrane irritation. Obviously, keep it out of the mouth and the eyes and whatnot, but certainly the skin itself can be irritated as a result of use. So similar in function to benzoyl peroxide is one called azelaic acid or Azelx. And so basically, we think this works pretty similar to benzoyl peroxide in terms of activity against you know, P. acnes. Also, interestingly enough, it actually is thought to help inhibit this conversion from testosterone to dihydrotestosterone. So testosterone to DHT. If you ever heard of that name for that steroid there or hormone. So what's interesting is, you know, testosterone is the main, you know, sex hormone produced by males and to a small degree by females. But interestingly enough is that it doesn't have as much activity as this sort of byproduct of its conversion. And we'll talk a lot about this when we talk about things like benign prostatic hypertrophy and a lot of urinary issues like BPH specifically. And so what you tend to find is that DHT actually has stronger androgenic effects because these are both androgens. They have androgenic effects. DHT is stronger than testosterone is. And so if you can inhibit that process, that can help to lead to some of the hormonal changes that may kind of worsen this acne here, right? Because we know that sex hormones definitely have an effect on acne for patients. Again, it can be variable in how it affects them, but this is one additional way they can have this. So if you had a patient, especially a female patient, for instance, who has had kind of hyper androgenic due to like maybe PCOS or something like that, and that's worsening their acne, this may be good because it can help to block that testosterone from being converted over to the more potent form of it of DHT, right? So just one thing about there. And again, start daily, increase twice daily to see how they're responding to it. Here you're going to see that you know, typically therapy needs to go on for several weeks to really get a good idea to see how it's working, to see if it's how effective it's being. And again, if they stop taking it, chances are things are going to go back to where they were previously, right? So they continue consistently. I can lead to some hypopigmentation of the skin, so that may be something, you know, there. If it does happen, you know, maybe slowly reversible, maybe not. Just so then, stepping it up, now we're going to move over to our topical retinoids. I know some of these have become over the counter. In the past, some of these are going to be prescription only. These are sort of kind of going up a step from things like azelaic acid and benzoyl peroxide. But basically, these are going to be forms of retinoic acid, which is the acid form of vitamin A. Okay, and so we don't know the full mechanism for how the topical retinoids work, but we think they help with the keratinization process, right, to help open those up. Can help to have some antimicrobial activity against P. acnes, and overall they have anti-inflammatory effects as well. And so basically, you're going to find that this is something that, you know, if your patient's been trying benzoyl peroxide at home and they've been trying, you know, pretty consistently, and you're like, it's probably not going to work for them, you may step them up to the topical retinoids. Okay, and this will be important too, and we're talking about using combinations of drugs because there's going to be some limitations on that. We'll see here in just a but you know, you can see this used first line in a lot of cases here. Also, some patients will use it for things like wrinkles and dyspigmentation. It can have some hypopigmentation sort of effects as well, similar to the azelaic acid we saw before. So these are going to be, you know, they're a step up in terms of efficacy from something like benzoyl peroxide, but again, they're also going to be a step up in terms of the irritation they can cause. So things like erythema, desquamation, burning, and stinging of the skin. This does decrease over time as the patient sort of gets used to it, and you can also use the help of things like emollients, right? Emollients are things that help to hydrate the skin. This is things like, moisturizing lotions, things like Aquaphor. Top of my head, I always like to joke about Aquaphor because I would say like, oh yeah, I'm giving you the good stuff. This is Aqua 5, better than Aqua. But and two, you're gonna also see a lot of photosensitivity here. So again, it can be a problem in Florida. Patients are trying to get out. Maybe they don't want to necessarily go out to um, you know indoor closed spaces. So they want to go out to the beach or something where they can stay 6 feet away from everyone, still get some sun. Um, Sunburns are going to be more likely to occur here, right? So you need to make sure they're covering up. Sure they're using high SPF sunblock. Closer to 100 the better, in order to prevent photosensitivity from. The other big thing too, you typically want to avoid these in pregnancy. Now we'll talk about isotretinoin in just a little bit. But anytime you're messing with fat soluble vitamins in a pregnant patient, it's not good for the fetus, right? Let's say fat soluble vitamins. I'm talking about A, D, E, and K, ADEC. If you mess with those, there's a high propensity to cause teratogenesis in the fetus there. So they typically avoid this in pregnancy. But think about these patients here. Are they going to be of childbearing potential? Very likely. So you need to talk to them about using backup protection. See if they're on birth control. Some patients will be on birth control in order to help treat their acne. Some people, the acne gets worse with birth control. A lot of different factors will go into this, but you need to have that conversation with them to make sure they're taking the stuff safely. Now, tretinoin itself, kind of the original one here, is photolabile, which means that it actually gets broken down in the presence of light. And so this is actually something you apply it nightly to avoid sun rays from being able to break it down there. Right? Also, this is something that with tretinoin, you would not want to use it at the same time as benzoyl peroxide because that actually will inactivate the tretinoin as well. So maybe they could be on a regimen where they do benzoyl peroxide in the daytime, and at night before they go to bed, they would do the tretinoin alternative, right? Could be one way to do it. Now, instead, we have some newer ones which are going to be a little more stable here. So, for instance, like adapalene or differin is stable in sunlight, right? It's stable with benzoyl peroxide and tend to be a little less irritating. So that may be able to get around some of that those situations there. Now, some of these stronger ones here, things like tazarotene, alloretinoin, and bexarotene, actually are not used for acne as much, but can be used for other sort of skin manifestations of different disease states. So, for instance, like alloretinoin having some effects for cancers like Kaposi sarcoma, using bexarotene for T cell lymphoma. I'm not going to get super in depth on these, but like the tazarotene being used for things like psoriasis and things like that. So you kind of even a step above in terms of inflammation from something like acne. So again, adapalene probably going to be the more common one you run into that and regular tretinoin. So we can also use some topical antibiotics here. So things like clindamycin, erythromycin. Can see some resistance here, and the thing with topical administration of antibiotics is that typically you can get like a lot higher concentrations than you could if you're say taking a tablet. So from a side effect profile, you're not really going to see much systemic effects. Like you would never expect to see C. diff infection in a patient taking topical clindamycin, right? Because they're just working locally. But they do get really high concentrations, and resistance shouldn't be too much of an issue. But we are starting to see some resistance over time due to the acne. So again, topical antibiotics may only get you so far. Typically, you'll see them in combination with other things like benzoyl peroxide, and that's the benefit though. They lack any systemic side effects as opposed to some of the oral ones we'll see here in just a little bit. So I got about 10 minutes. So what do you do when topical treatment's not going to be enough for your patients, right? So they've tried all the topical stuff, the topical antibiotics, they've tried the retinoids. Nothing's really working for them. Still not working. Well, this is where we're going to start to get into systemic therapy, right? And so this is where we're going to, first off, we're going to talk about the systemic retinoids. So just like we have tretinoin used topically, now we have isotretinoin being used orally for systemic purposes. It's going to be better for patients who have maybe more diffuse disease. Maybe it's covering a wide surface area of the body. More severe. Maybe it's been treatment resistant other stuff. This is where you bust out the isotretinoin. Note here as well, this is really, really important. You do not use this in pregnant patients. Ever, ever, ever. In fact, there's something called a REMS system they use for drugs like these. REMS stands for Risk Evaluation and Mitigation Strategies. Certain drugs that have a likelihood of causing a very severe adverse effect will be under one of these REMS programs, right? So if something is very likely to cause fetal birth defects or death, it gets a REMS program, right? If something is very likely to cause agranulocytosis, it gets a REMS program. And so this is the first one we've actually looked at that has one of these. And so this is a case here called iPledge, where the provider has to be registered with them, the patient has to be registered with them, and then the pharmacy has to also be registered with them. And they undergo all of this to make sure that there is very little risk that the patient who's taking this um, becomes pregnant. Because if they are on this while pregnant, it can lead to some very severe effects and fetal demise potentially in that patient. So don't use this while they're breastfeeding, while they're pregnant, anything like that. And again, weigh the risk versus benefits here. If the patient really wants to become pregnant, maybe they're okay with their acne not being as well treated. It's all about conversations with patients. But even in some cases, I say men should also avoid it as well because there could be some transfer during sex. You can see some transfer over to the female patient when she becomes pregnant there. So even those male patients have to be part of this program as well. For females, it's a little more involved because they actually go through and have to have counseling on birth control and have to have pregnancy tests done, documented regularly. So it's a big to do. Um, but this is a very effective drug. It's very good at what it does. And so for some patients, the hassle of going through this system is worth the effects that they get from it in the end. So what are those effects? It works very good for the acne, but the adverse reactions are going to be similarly increased, just like we saw from going from the topical retinoids to the systemic ones. So you're going to see a ton of skin irritation. And again, it's not just where you apply the drug because it's everywhere. You're taking it orally. Photophobia. You can end up seeing a lot of arthralgias and alopecia because again, it's affecting vitamin A throughout the entire body, leading to a lot of this irritation there. Also, one thing that's really kind of interesting that you may not think about is watch out for signs of developing depression. There is a increase in risk for depression, can worsen depression in patients, maybe even some risk for suicidal ideation, suicidal acts. So you gotta be really cautious with that. Make sure that people around them know to monitor for this to make sure it's not something they're going to develop there. So very good drug for what it does, but a lot of caveats to go along with that, a lot of side effects to worry about. In terms of systemic antibiotics, these are going to also be used for more extensive, more difficult to treat disease. This is where you get into our tetracyclines being used probably most commonly. But again, think about all of the things we talked about in terms of its like chelation, talking about who we don't want to use it in. So most often kids less than 8 and pregnant women, things like that. Alternatives you could use to the tetracyclines. I mean, because these are like dirt cheap, so this is where most people start out with. But things like Bactrim, azithromycin, ciprofloxacin have been used occasionally as alternatives, but you won't see it as commonly there. Tetracyclines definitely, you will see. There's some other therapies to get into as well, which I'm not getting super in depth on. But things like salicylic acid, right? So it's kind of similar to aspirin, but we know we can use this topically for sort of keratolytic effects. So this is another thing you'd find over the counter that some people have mild, benefits with, but also it being a salicylate has some anti-inflammatory activities and things like that. But used occasionally. Sometimes anti-androgens can be used here. As I mentioned before, testosterone being converted into DHT can have some effects and worsen the acne for some patients. So in some cases, we can give them anti-androgen products. That can include things like spironolactone. This is actually a diuretic drug. We'll talk much more about this when we get into the cardiology section later on. So you can kind of keep this in the back of your mind, but it also happens to have anti-androgenic effects and can be useful for topical therapy for acne there. And then oral contraceptives is sort of one where it really depends on the patient. It depends on sort of which ones they're receiving. I mean, if you look at the total list of different types of birth control that are out there, I mean, the list is like a gazillion long, right? Different doses of estrogen, different progestins that are included with them. We'll talk more about that in the OB-GYN section later on. Why is it to say is that some women will develop positive effects from this, will have good effects on their acne. For some women, it worsens their acne. Can't really tell. It just depends on them trying it out. Typically, they'll try it for 3 months, see how it responds, how they respond to it. If it doesn't work, they go on to the next one, right? And then try something different. But again, these are going to be most likely required for patients who are going to be on isotretinoin for sure, right? Unless they have some direct contraindication for it. See, Ellie was asking how long can patients be on oral antibiotics for acne? I don't know, as long as long as they want to be on it. So if it's one of those things where if you see somebody who's taking antibiotic with no explicit duration of time, that's usually going to be used for acne purposes. And yeah, they can try it for a while. Some people will sort of outgrow their acne, as they grow into adulthood. That can improve. For some people it doesn't. So they can be out for quite some time. Could be months, could be years. Depends on the patient. In cases you may even see things like intralesional steroids. This can be really good for patients who have like a significant strong inflammatory nodules, but don't use this quite so frequently there. More for the inflammatory type of acne there. You can see some absorption there, which can lead to that adrenal suppression, which we'll talk a little bit more about in detail later on. And I mentioned before, corticosteroids themselves can actually cause acne, but in some cases here, you can find that low doses can actually help to reduce symptoms. Those are going to be people who are like in adrenal hyperactivity. So if they're like producing too much cortisol on their own, you can actually use this to sort of kick off that negative feedback loop and help to decrease production of cortisol in the adrenal gland. So typically more for like inflammatory disease, short courses would include things like prednisone, dexamethasone. These are therapies you would not use unless you had a really specific reason to. If you're working in family practice, you're not going to be doing these. These are going to be more so in the derm office sort of thing. Right? So I want to end on this slide here, I think. Yeah. So review this. You can kind of see we want to go sort of on a stepwise approach when we're doing this. And so, for instance, I might ask you on a test question, I might say a patient comes in complaining of acne and they've tried this, this, and this. What's the next best thing for them to go up to? Or you want to start them on this drug. What's the best counseling point you want to tell them? Or, which two drugs can you not use together? Things like that. Those are kind of the things I might be looking at. But when you're looking at which drugs to choose for coach, if they have maybe it localized just to one area and they've not tried any over-the-counter stuff yet, start off with some topical benzoyl peroxide, right? Start off with maybe potentially a topical retinoid, and then if it's not improved, then you can step up your game a little bit. Maybe start to talk about using topical antibiotics, right? Maybe that's not working. Then you want to start consider things like systemic antibiotics, okay? So kind of go through the stepwise approach there. Start off topically, then move on to the oral stuff, unless they have very diffuse disease, very severe disease. Then you can consider skipping some of these and going straight to things like systemic retinoids, right? So you kind of have a feel for that in terms of what we're going to be doing here. And then those are kind of the types of questions I'll ask. I'll give you some more examples before the test, though. Any questions you guys have? I'm going to end it for today. The stream's kind of out there a little bit. Someone said benzoyl peroxide and isotretinoin wouldn't work against P. acnes, but are not considered antibiotics. Why exactly? That's a good question. Mainly because we don't use them to treat infections specifically, right? I could use benzoyl peroxide, but itself is not really designed to be. It doesn't work specifically as an antibiotic, whereas like clindamycin works specifically on bacterial protein synthesis. This just has some additional side benefits. Of having antibacterial activity. That's why we don't classify them as antibiotics. That's not their specific purpose, is what I would say about that. Any other questions from you all? If not, we'll have the quiz next week. I'll put up an announcement about that. I'll also put up the prescription assignment today. I apologize for the delay on that. You'll have 2 weeks to work on it, which is plenty of time. 3 scripts. And then we'll go from there. So I'll have it set up through Lockdown browser. So you take it wherever you want. I'll have the camera thing on, so I'll have to do like the check the room and all of that stuff. And then you'll take it probably about 15 minutes, probably like between 5 and 10 questions. I have to write it. And then we'll go back to the lecture, and I got the link there, so we'll start up at 8:30, I believe, that day. Up at the Yeah, so next week we'll start at 8:30 and then continue until 10. So, all right. Any other questions or anything you guys out with? If not, you're free to go. Have a great weekend, and I will see you next time. end the stream. I'll see you guys later.